Welcome to another episode of G&T. Today we will be talking among ourselves today between me and Dr. Gunnar, just sharing some different key points, some ideas. We want to have a guest every time, but sometimes it's good to just talk among ourselves and express what we like, what we don't like, and things that we believe where bariatric is going to go and so forth. It is a dynamic field. We've been pretty busy, which is great. We've been helping a lot of people as we proceed in this journey. It has been a very interesting journey for me for personal growth also. And I think the same way for Ghana. There are a couple of things that people always ask when they come to see us in the office. One of them, they talk about it. I want to do this, but some of my friends are telling me, or my family members are telling me, this is the easy way out. And I think it's the opposite, right? This is but easy way out, right? People don't understand that bariatric surgery, it's a tool that allows you or help you to achieve your goals, right? What do you think about that, Gunnar? Do you think is the easy way out, or what's your thought on that?
Right. So definitely not. It is not the easy way out. It is the way that works, as I heard it once, and really that describes it well. It is the only way that has been proven to work and to sustainably work. As I always say in the seminars, and you say that all the time as well, diets work temporarily. You will lose weight, but you'll not be able to sustain that weight. The reason for that is because mostly your body still needs to consume those 3,000, 4,000 calories that you were needing to consume prior to your weight loss. And as a result, you feel starving all the time. And that is never going to be sustainable in a very low percentage of patients that is sustainable. So definitely it's not cutting corners. It's not the easy way out, but it's rather it is the sustainable way and is the way that works, and that is very important to remember.
I agree. I agree with you. Um, you know, if you look at, there's a lot of data that came out. You look at the Stampede trial, right? Stampede trial that came out many years ago. It's one of the best trials done in terms of obesity, right? In terms of diabetes, that compares surgical intervention versus uh, medication intervention for obesity, for diabetes, actually. So it showed that, by leaps and bounds, the surgery had better outcomes versus just medical therapy alone, right? And the patients actually that were in medical therapy alone had to be added on more medications at the end of the trial compared to the people that were on the surgical arm. So what I tell my patients is that it's not the easy way out. You have to think about different ways. This is a weight loss operation, but it's also a metabolic operation, right? If you don't take care or gain control of especially your diabetes, you will end up with most diabetic patients that are not controlled, which is infections, the amputations, and then cardiac disease, and blindness, and so forth, right? Among with other diseases. So it's definitely not the easy way out. I think it's a way for you to prevent the history to repeat itself on your own family, right? That's one thing. Also, for you to decide to have an operation that's going to help you achieve your goal or get rid of a lot of your medical issues, it's not an easy way out, right? It is actually a way for you to face your problems that you need help. Okay. I think the hardest part of all of this, right, is what comes after the bariatric surgery, right? Is your lifestyle change, especially if you are an emotional eater or a stress eater, right? Now you have to deal with that stress. You have to deal with that um, uh, emotion, right? You have to face your fears, right? And that's why it's so important that we have our own behavior therapists in our office, because when we see that, when the patients are coming to see us in the office, we connect them right away, right? I that's what I think. I don't think this is easy. I think this is all the way around. It's probably
Right.
the hardest way.
And I think, the ultimate test eventually is the result on the ground. And the result on the ground currently, and this is not specific to any region, is that currently we're suffering from obesity, not only nationwide nowadays, but worldwide, and it's such a high percentage, which would mean that whatever we do conservatively is not working. And if it's not working, then we should abandon that and go to what we do have to be proven scientifically and on the ground to be working, and that is the metabolic and bariatric surgery. And so we can say, people, this is the easy way out. Will tell you that most people who have not suffered from this chronic disease called obesity will not understand what you go through because their genes are different, their metabolism is different, their day looks different. It is not something that they will be able to understand unless they are going through it. And as a result, they think that it's as simple as, oh, cut down your calories, exercise a little bit more. There you go. We have our problem solved. Another thing that, right. Another thing that actually, since we were here and we're talking to, I wanted to pick your brains on while you're at it, since you've been doing this longer than I have. One thing that I struggle with often is the patients that come to me already with determined on a specific operation that I, as the surgeon, do not agree with. And they come telling me, hey, I want the sleeve gastrectomy. I talk to them more in detail. Turns out they have severe heartburn or reflux. And so that would be, of course, as you know, not the ideal operation for them. And I would try to sway them away towards the bypass, which would be a fantastic operation to them. But they relate more. We as humans relate more to stories that we've seen, right? And they might have heard somebody in their family that had a bypass 20 years ago, back when surgery was open and much more complicated, and had some issue, and as a result, they give quite a bit of pushback. How do you deal with that? What do you think about
Cor- Yeah, great question, right? I mean, we see this every day in the office, right? We have patients with super high BMIs, or like you said, severe reflux with Barrett's esophagus, which is a change of the lining of your cells in the esophagus, which is a precursor for cancer. They want to have a sleeve because their friend or their family member had a sleeve and worked for them. Well, I think it's on us to, first of all, to educate the patient, right? What are the different types of operations and what will be the best option for them long term? I don't care about 1 year, 2 years, 3 years. I care 10 years, 15 years, right? 5 years, right? I mean, I care long term. So for me, that's what comes into play. If a patient has a contraindication, a true contraindication for a procedure, then by no means we should do any of the procedures that they want, right? Just because they want does not mean we should do it, right? So I tell them, if they have a specific contraindication, I will not do it. And if they don't want it, that's fine. I mean, it's okay for us to say no, right? We don't have to always agree to what the patient wants. In the end of the day, we are professionals, and we've been doing this for way longer than the patient has. And so they should at least listen, right? I'm not opposed to do the workup and so forth and go from there, right? But if they have contraindications, for sure, I'm not going to do it, right? So that's what I tell them. And if they have severe reflux, I say, listen, let's do the workup for reflux or GERD and see what it shows, right? If it is due to something that we can fix surgically, I'm okay with it. But at the same token, we tell the patient that, hey, listen, it's getting more difficult for you to get revisions. With a higher BMI, right, greater than 50, the chance of you have a BMI less than 30 with a sleeve is less than 5%. That's data, right? And well done data. So if they have a goal in mind, the chance of their reach is pretty slim, right? So I just educate them. It's our job,
right?
And I'm pretty sure you do the same thing.
Right, absolutely. And we are a referral center, and we get a lot of patients from other centers that have had procedures done in the past. And we've always seen, probably at least once a month or so, we see that patient that had severe reflux, had a sleeve done nonetheless, and now they have changes in their esophagus because it's pretty much burned from that acid reflux that could eventually, if ignored, lead to cancer in the esophagus. So it's definitely something not to be ignored and tampered with.
Correct. 100%. 100%. Agree with you. Since we're all on the topics, right? We talk about different things. I think we should name this the top 10 things that we want to talk today, right? I think the top 10 thing on GNT today. I think it's good. We're already talking about two things: the easy way out and the sleep with the reflux and what the patients want. I think there are different things we can talk about. You know, I see sometimes patients getting really upset with the pre-op process, right? The pre-op. So I think the patients have to understand that we don't have control on that, right? You have to do what the insurance requires you to do. If your insurance requires you to do 6 months of diet, you have to do. If you do 3 months of diet or three diets or visits, you have to do it, right? So there's no other way around with that, right? The only thing that we request extra, if the patient is a cardiac patient or pulmonary patient, you have to have clearance, renal, so forth, things like that. But the diet valve, nutrition evaluation, psych eval, diet documentation, you have to do it. There's no other way around here, right? That's one thing. The other thing is that you can have insurance, but if you don't have a bariatric coverage, insurance will not pay. You can write 10,000 letters for it, and it's still going to deny it, just like a contract, right? It's a contract that you sign with the insurance company. If the contract doesn't have a policy for bariatric coverage, they will not pay for it. I know you probably have encountered that too.
Right, absolutely. And going back to your first point and regarding the process, we don't like waiting, and having the patients go through these hoops for 3 months or 6 months or whatever that may be, as much as you do. But really, my advice to you is not see that as wasted time, not see that as downtime that you can stay frustrated with. But I really recommend that you use that time to start working on your habits to maximize your success prior to after the surgery. And to maximize your success after the surgery, what you can do is really already cut down on the bad habits that you've had beforehand. Cut down on the sodas, cut them out completely. Cut down on the sweets. Start exercising more often. Start doing more protein. And once you get into that mindset for 3 months before the surgery, you will see that that will really actually give you much better results after the surgery. And so in that way, you've gained a lot in those 3 months, as opposed to looking at that as a wasted time for 3 months or so. And regarding what you touched about the insurance, we as surgeons and I would say probably nationwide are fighting this. We know that insurance companies hopefully can do better in terms of covering the only thing that has been proven to improve the patient's outcomes with obesity. But until then, like Dr. Teixeira stated, we really have no control.
Correct. So, Dr. Gunham, quick thing here. I think a lot of the viewers really want to know. This is episode number 8, I think, something like that, 8 or 9. They really want to know what's behind you, those two doors.
Right.
What do you have?
So these are the doors of the doors to the world of bariatric surgery. If I open door number 1, you get a sleeve gastrectomy. If I open door number 2, you get a gastric bypass, and door number 3 is a duodenal switch. So these are the doors to the world of bariatric surgery.
we had to ask, man. I mean, I think all the viewers are pretty interested to find out what's going on there.
It's a window to the
world. Listen, so the other thing I think is good for us to talk about it. A couple of things, right? One is, especially at the end of the year, right? I mean, summer coming in, people start to enjoy more or less term out, grilling, so forth, going outside with their friends. Depends where you live. You really don't have to stop eating what you enjoy it, right? Depending on which operation you have just to be careful if not a lot of sugar, not a lot of carbs, not a lot of grease, fried things, and so forth. you still can enjoy things with moderation, right? It's not about you not enjoying it, right? It's about choices and what goes better for you for what your triggers, right? Like for example, my trigger is carbs. Carbs are a big trigger for me, especially bagel. So I try to stay away from that. I'm not saying I don't ever eat. Yeah, sometimes I eat one or two, if most, but that's very far few in between, sporadically, right? So you just have to know that.
Right.
What do you think about that?
Absolutely. I just wanted, now it makes a lot of sense that you mentioned bagels because Dr. Teixeira always brings me breakfast of bagels. And I think now he's trying to set me up for failure, but I understand it now. But yes, absolutely. I always tell my patients that extremes are bound for failure. If you are going to go on this extreme diet, which is again why we mentioned beforehand, if you're starving all the time, guess what? It ain't going to work. If you go all of a sudden and start exercising, twice a day, every day, it's not going to be sustainable. Extremes might you might be able to maintain that for a week or two, but it's not going to be something sustainable and it's not going to work. And hence, you should be able to enjoy your diet as well within moderation. And so you have to always make sure that, here and there, if you do like yourself some, for example, rice, have it within moderation, maybe small portions once a day, maybe on the weekend when you can slightly indulge a little bit in something that you usually should stay away from also. For me, like you mentioned, it's really sweet. Not big on sweets, but if I like it, once every 2 weeks on a weekend, I'll go get me some ice cream, right? And I'm good then afterwards. So that's definitely something you want to sway away from, and that is the whole purpose of the surgery, to be able to develop a new healthy relationship with food. If you are swaying away towards the extremes, this is not something you can maintain. Neither should you maintain that also on the long term.
I agree with you, right? I mean, I think all of those you have to also enjoy a little bit. The same thing goes with drinking,
Right.
right?
Abs-
With alcohol
right.
consumption,
Absolutely.
right?
Yeah.
I
Yeah.
think you just have to be
Right.
careful.
And this is one thing that most patients that have had bariatric surgery should be very weary of. That alcohol can be quite dangerous after bariatric surgery, especially if you've had a gastric bypass, as it can get you a bit tipsy quite quickly in smaller amounts, much smaller amounts that you've had beforehand that would cause that effect. And as a result, can develop dependence, liver issues, of course, not to mention weight regain, which would be the least of the issues at that point, if really that happens. And even regardless of the surgery, this is something that you should enjoy in moderation as well. Right. And looking at exercise as well, right? If you overdo it, it's going to increase your metabolism. You're going to be spending a lot of calories that sometimes can lead to weight regain too, and of course can lead to injuries, fatigue. So even exercise, that's not something that you want to do in excess. Which, speaking of exercise, Dr. Teixeira, and did
Tell
you end
me.
up getting on your Peloton? Because I heard that you have not registered the workout for quite a while. Still.
That is true. That is true. I haven't done my Peloton in a while. Actually, I promise myself I'm gonna go back in starting this Saturday.
Just like you said last Saturday.
I have to. I actually have to. I have to because it's a a challenge I have here at home with my wife, so I have to.
Well, I can bet you're losing now.
No, no, I never lose. I'll be fine. So let me ask you
Hmm.
something. Um, how do you help the patients, guide them, or help or guide them in, let's say if you have a 36-year-old female, BMI 40, right? Mild reflux, right? Hypertension, let's say, PCOS. How do you guide them to choose them the operation? I mean, how, if they come and say, Dr. Gana, I want you to help me out choose the right operation for me. How do you
Right.
guide
So
them?
I think it goes back to what you mentioned beforehand. It is really on us to educate the patient And so what I start with is that I explain all the different operations to every patient, even if I think that they're not suitable for this operation or that operation. We mentioned patients with reflux beforehand, and then the sleeve would not be suitable. And so even then, I still explain to them what the sleeve is. And I think once I educate them why I think this surgery is not suitable for you, they seem to, at that point, agree with the choice that I sway them towards as an expert from my opinion. And it really comes down to understanding. So I go down and I start down by explaining to this lady, for example, who said she has severe reflux and a BMI of 40 and PCOS. I tell her that one option is a sleeve, but I don't think this is a good option for you. And I explain to the lady exactly why a sleeve is not a good option for her. I explained to her why it makes reflux worse by showing her the diagrams in the picture, and the mechanism of reflux after such an operation, and why I believe it's not a good option. And then I jump onto the bypass and I explain the bypass as well with the diagrams and why it's a better operation for reflux. And then I go ahead and explain the duodenal switch anyway, even though you stated, I think, a patient of 40, BMI of 40, usually most of the time, with exceptions, of course, you don't want to do a duodenal switch on these patients, even though that can be done, of course, with exceptions in certain patients. I still explain to the patient anyway, and then I say, okay, my recommendation is a bypass because of what I mentioned. And most of the time, once they are truly informed about the physiology of the operation and why this is better and why that is worse for them, they are on board, with exceptions, of course, and like we stated beforehand.
Uh, yeah, I agree. I pretty much do the same way, right? I mean, you have to educate the patient, look at how the patient, the dietary choices, right? Level of activity, how they work, and so forth. Also, see background. I look at culture, right? I see culture has a lot to do with it in my mind. So I look at all of that to be able to help the patient, guide them a little bit more, right? And to me, that's one way to connect with the patient too, right? Understand the culture
Oh,
too.
absolutely.
That's great. This is all great stuff, man. This is all great information. I think the more information we give to the patient, the more it's
It is,
fantastic.
and what you mentioned is key, really, with the culture. And me, for example, as somebody comes from the Middle East, I know that our foods tend to be just loaded with carbs. And again, we talked about it in a separate episode, and the confusion between Middle Eastern and Mediterranean diet, which are not exactly the same. The Middle Eastern diet is just loaded with carb and revolves around carbs, which is the biggest issue.
Are you sure you're from Middle East?
I am Jerusalem, born and raised. Right.
You look like from Brazil.
Actually, I get that a lot.
No, you don't. Such
I
a
get that a
liar.
lot.
You wish. You wish, buddy. You wish.
Right.
You don't have the accent.
I don't know. People tell me I do.
Yeah. Listen. So another topic, I think, to close the what we've been talking here, it's relationships,
Right.
right? It is very common for your relationships. Not, I'm not talking about relationship with your better half. I'm talking about even relationship with friends and so forth, family members change, right? And I see that very often. It's not in a bad way. It's always in a good way. Meaning, you tend to gain your confidence back, right? You tend not to put up with anything anymore because your autoesteem or self-esteem is pretty high, right? Which is all good stuff, right? So in my mind, you are getting rid of or decreasing the relationship with people that put you down, right? So that's what it tends to do. It's not a, sometimes it can be hard because you had a relationship for 10, 15 years, but in reality, it was not a healthy one, right? In the same token, it can also make your relationship stronger, right? With your better half or your whatever, right? And I think that's also another way that we sometimes we don't see that because patients don't like it, but we can tell that, especially when people are back to their normal weight, quote unquote, or they feel comfortable or they feel sexy with it, right? The relationship with the partner more becomes more lively, should I say, right? So, and I see that a lot too, and I think it's phenomenal when we see that this kind of stuff. What's
Right.
your experience been with that?
Right. I mean, I've seen it as well quite a bit, and I think it's what you stated beforehand. It's not necessarily a bad thing. If I'm used to my interaction with you as Dr. Teixeira, of you, for example, being somebody who is talkative, just as an example, and all of a sudden you are somebody who is very reserved, which is not a bad thing either, but that will change the dynamic, and I'm going to think that something has changed, and it's going to change the dynamic between what I know you for 7 years now. All of a sudden you are a different person, and I'm going to think something is wrong. So the same thing really after weight loss surgery, because of all of the reasons that you aforementioned. It's not necessarily a bad thing, but people have known you all of your life as this person, and then all of a sudden things are changing about you, not just the looks. And I'm not talking just about your looks. They're talking about also what you mentioned, the confidence, the way you carry yourself, and that is probably gonna take some time for them to adjust to that. So what I usually recommend, and I'm not by any means a psychologist, of course, or an expert in this, but I would say just give people time to adjust. Usually, once they get used to the new you, they'll be fine. And the other thing that I also would say is try to kind of prepare them gradually as well to what there is to come prior to the surgery, so that they can be more prepared. And what I've noticed in life in general is that the more they understand, the more the people basically accept you, and the less issues you will have in general. And somebody has once written, so I've read this in a book once, that the other word for love is understanding. It said the other word for love is understanding. So the people that really understand you, they will accept you better. They will have less issues with you and less queries with you as
So now there is a question I really want to ask.
well. Right.
Does your fiance understands you?
She is the one, she is the only person that understands me to this higher level,
Exactly.
right? And you know
She's
that.
the only one.
This is why she's tolerated me so far. Now,
Exactly.
why is going to be it? Why
Exactly.
is something that is beyond me and I cannot explain. But
That's why I told you when I met her, I said, go ahead, man, propose her because this is your last chance.
I do not disagree.
Awesome. This has been a great time, a great episode, I think. We got good information. Stay tuned for more episodes to come. Um, thank you very much, everyone.